So the question, the sort of broad beginning question is, why did you use a state plan amendment to do what you did?
We amended our state plan because we were already in the state plan. What we had to do recently was change the state plan from a bundled rate to a fee-for-service rate, but we had been in our state plan since the 90s.
And who made that decision, or who did you have to work with or convince to move in that direction?
So we really didn't know what we were going to do when we were told that we needed to move to a fee-for-service system. We put it off. I don't know if you remember or not, but there was that 2010 letter that basically told everybody to unbundle. And then finally, our General Assembly in the Office of the Governor tried to put birth to 3 in our Medicaid lead agency. They didn't do that, but what they did do was they moved the funding, a portion of the funding, into the match. And in that scenario, it was, you are getting this funding moved over here because you are going to fee for service. And we hemmed and hawed and finally discovered that, okay, they're not kidding. We absolutely have to do this. And we approached our colleagues over at DSS, which is our Department of Social Services. They're the lead agency for Medicaid in Connecticut. And the attorney on the team, his name is Joel Norwood, and what a helpful guy. He just said, you know what? We just have to amend your state plan. And it's like, okay, what does that mean? I mean, really? We kind of didn't even know anything. And they just walked us through the process, which is remarkably complicated. And then we gave them the information they needed to be able to put the wording into the state plan.
And so Medicaid actually executed that for you.
They did.
Collaboratively?
Yeah, they did. Oh, I mean, honestly, it's funny because, you know, there's lore and then there's reality. And the lore was, don't talk to DSS, you know, they're Medicaid. But in reality, these people were great. They were so helpful to work with because they could explain things to us. The process of getting CMS approval of a state plan is one thing. But we also discovered that when you go to fee for service, we went through different approaches and decided to use EPSDT. And with EPSDT, there can't be an age limit because it's really birth to 21.
Right.
So we had to figure out how to word that. And then we also realized that there's any willing provider provisions in Medicaid that we did not want. So not only did we have to do a state plan amendment, we had to do something called a 1915 B4 waiver, which allowed us to waive the any willing provider provisions and do an RFP so that we could select qualified birth to 3 programs. We wouldn't have known any of this if we didn't have our DSS team leading us, really.
And was there any concern, I guess, by anyone involved in this process at the higher levels or not, and correct me if I'm wrong, but when you do a state plan amendment, it theoretically can open the whole state plan up for other amendments that someone would like to bring into that process, and that's why some people don't choose to go in that direction. Was that ever an issue?
I honestly never heard that. In fact, I think our state plan is being amended all the time. They did an amendment for autism supports for children over 3. There's all sorts of amendments being done. In fact, the attorney that we worked with, that's his job, really, is amending the state plan and working it through the system.
But those are not those typical of things that the Medicaid agency wants to do or is told they must do. And I ask that in context of other states that may want to go in this direction, where it's not, in essence, being told to do from above. So you're not going to get much pushback. But if if it changes other options that a state has that other people want to push. It's always been my understanding that provides a vehicle for someone to try to do other things that someone might not want to take place.
Well, and there is a public hearing component to the CMF's approval process. So absolutely it could. I would say the fact that ours was coming from the Office of the Governor down and CMS, that our Medicaid agency was the one really driving the bus. You know, they were saying, we got to do this. You got to go to fee for service. We can't do bundled rate. Because also, I think, given the 2010 letter, our state plan was so old, it was probably out of compliance with CMS in other ways. And our Department of Social Services just wanted to clean it up to begin with. So I think they were highly motivated on many levels. And when you've got that kind of top-down and grassroots support from your Medicaid lead, it's much easier. But yeah, I would say a state trying to do this on their own would need to start with whoever can influence the Medicaid lead commissioner, because that's where it needs to come from first.
So that potentially goes across a variety of state agencies, might it not?
It might, you know, I mean, really, it even came down to programming the software at DXC, formerly Hewlett Packard Enterprises. DXC is who administers the MMIS system, coming up with all of the tiny little rules. So there's many, many layers to this onion, and you definitely want to start at all of them at the same time so that you can make sure that you're not missing anything.
Well, let me go back. I know this is sort of right in your wheelhouse that you'll want to talk about a lot, which is, was there additional data in this whole process that you had together? And kind of coupled with that, were there any expectations for you or your team to calculate costs of making the change? I mean, was some of this the ability to generate additional revenue, or was it very specifically decided because of the moving away from bundle to a fee for service?
I think the real motivation to get us from bundle to fee for service was because we were experiencing annual deficits just with the growth of Part C, and it looked like we were leaving money on the table. We did have a governor's office and Office of Policy and Management who realized that this might be a way to bring more federal dollars into the state. So if your chief executive doesn't want to bring more federal money into the state, it's a harder battle, right? We had a governor who supported bringing more federal dollars into the state. So we knew that that was going to happen. We helped our Department of Social Services by using the utilization data that we had, hours of service and numbers of children and all of that, to be able to project, you know, well, if we're currently getting this much money and this percentage of children are insured by Medicaid, what happens when all of the children, I'm sorry, my phone's ringing in the background.
I think anything where you've gathered data that helps move this along and forward that people want you to have. There's a second question embedded in that of how much revenue, additional revenue, do you think you did generate? And did that have impact on state match in terms of how the state was putting through Medicaid? How were they putting their state match into the process?
All right. So we knew that switching to a fee-for-service model was going to generate more revenue, because when you're paid a bundled rate, fine, if there's only one service in the month, you might get $800 or whatever it is. But for children who are receiving intensive services or families who are getting intensive supports, you are looking at a total loss. They might be getting 10 hours a week and you're still only getting $800 from Medicaid for that 40 hours of service. So all we had to do was go into the service utilization data we had for children with autism and show them what that would look like in fee for service. And it was a huge selling point as far as the budget makers go. Now, our Department of Social Services, they realized that it was going to end up costing more in the match, but little tiny birth to 3 was just put into the Medicaid budget line along with the hospitals, you know, so they kept saying, please, your funding is not even a rounding error for some of these other people. And I think that's important to have that context, to be able to say, we're not talking about a lot of money. It's still a lot of money, but relative to the overall Medicaid budget, it was not a significant impact.
Very good. So I'm assuming from what you've described to this point, there was no opposition really to this action, unless there was opposition from the provider community. And if you could speak to that, if there was opposition, and how did you address that?
Yes, the opposition was from the provider community. They were very unhappy about the idea of moving to fee-for-service for many, many reasons. We lost a couple of really high quality programs because they just didn't want to bill Medicaid. They did not want to be part of the Medicaid system. And so they dropped out. And that was heart crushing, you know, to actually lose programs that you've been working with for 25 years. So the remaining programs continually pursued. We went through 3 commissioners during this period, and each new commissioner got the same argument, which was, don't make us move to fee-for-service. We don't want to have to go to fee-for-service. And the commissioner would get up to speed very quickly and say, we don't have a choice. We are doing this. It's the right thing to do. You know, it was hard because on some degree, we do like a bundled rate. A bundled rate gives our programs more flexibility. It supports the practices that we want that may or may not actually be billable. But at the same time, I think it might have been the past Massachusetts Part C Coordinator who said that providers actually need to have some skin in the game. And I do believe that. I think there's an aspect of having providers participate in billing that made a difference. We did find a contractor. We went out to RFP. We found a contractor who was willing to do the middle work, you know, all of the electronic file transfers. And that made it more palatable. But we had to have regular meetings, you know, talk about leading by convening. We were just absolutely in the faces of our providers constantly with updates and information, and there couldn't have been enough communication to help with the anxiety, basically, of the shift.
And I think you would probably suggest that anybody who was wanting to do something similar are significant changes in a billing system based on this action or private insurance. You're likely, if people have not been billing third parties or their lead agencies, the provider's lead agencies, have not been billing to do third party payments, public or private, people are going to push back.
And not only will they push back, the programs will push back. So they may, the birth to 3 providers in Connecticut actually originally did their own, not Medicaid, but they did their own commercial insurance billing back in the 90s and the early 2000s. And then we found that some were doing a really good job and some weren't, so we centralized it. And when we centralized it, we discovered that we still weren't getting the kind of numbers that we wanted. So we used this as an opportunity to just redo the billing vendor completely. So it was a combination of fee-for-service and we need a better approach to commercial. But not only will the programs or the entities who are going to be responsible for doing the billing push back, it's going to get out to their families. And we had families that were calling their representatives saying, don't close birth to 3. And it was like, are you closing birth to 3? It's like, no, we're not closing birth to 3. That one program is closing because that one program doesn't want to bill Medicaid. But no, the system is fine. We had to do a lot of public relations work with referral sources who thought that the birth to three system was closing. I mean, there was just a lot of misinformation out there. So we had to work around that as well.
Mhm. And did that have any implication? This is a little more in the weeds, but did any of this have implications for family fees? Because correct me if I'm wrong, you do have a family fee system or not?
Yes, we do. We instituted family cost participation fees back in 2003. And we did have to change our system of payment procedure only because there was some language in there about how claims and services were going to be paid for. But the actual family cost participation fee process did not change at all.
And I assume very little of the family fee system would have applied for the most part for Medicaid eligible families.
Right. We have currently a $45,000 adjusted gross income entry amount. And so anyone who's insured by Medicaid or anyone who makes less than 45,000 doesn't pay family cost participation fees. And we're hoping to get that up to the Alice levels, but that's another budget discussion for another time.
So it sounds like in your overarching process that you went through, you hadn't tried this before because you wouldn't necessarily have wanted to. So it really was the downward pressure from those above you that sort of drove this, as opposed to having a change that you asked for and then continued to ask for, sort of building on a case-by-case basis. Instead, it was sort of all or nothing, but you knew it was going to be all of something because the people who were driving the bus were saying this has to take place, with a lot of mixed metaphors in there. So
yes, we absolutely, our line was, we have no choice in this matter. We have to go to fee for service. What's interesting is that currently, remember that letter was 2010. You know, we're now, when this all started, it was 7 years later, we noticed that Medicaid started shifting back to what they're calling event rates. And we were thinking, you know, are we going to unbundle just to have them tell us to go back and rebundle? And we talked with our Medicaid folks about this, our rate setter folks in particular, and they said, we don't have the data to create an event rate because you've never done fee for service since Part C started. So we have to do fee for service for several years before we're even going to have a conversation about event rates. But yes, eventually down the line, we could look at event rates. So right now, we were able to convince them that an evaluation is an event and they pay for the eligibility evaluation. But as far as trying to come up with an event rate for an early intervention monthly type fee, we have to collect this micro fee for service data first. And absolutely, we had no choice.
And that is so very of the issues that a child would be presenting with, of quote unquote, how many sub events are taking place within a given month.
Yeah, and we just had no data. I mean, even when it came to rate setting, our Department of Social Services looked to us for a year's worth of service delivery data. Actually, they needed 2 full years worth of service delivery data. And they used that for rate setting. They tried doing a cost report, but they all came in different and it wasn't clean or good data. So instead, they ended up using our utilization data to set the rates.
And I know you're recognized across the Part C world as around your expertise around data. Is there anything you would want to say other to the individual states that are applying for this activity, or more directed to the entire community about what people need to be collecting should they want to try to either do a state plan amendment or access Medicaid. What do people really need to be paying attention to data-wise?
You know, that's like when you're swimming in the ocean and someone wants to ask you a question about the fish. It's like, so you know, to me, it seems like, well, of course, anybody would want to be able to know how many hours of service are in an IFSP for any given child, Medicaid, commercial, diagnosis codes, all of the things that we look to for representativeness, equity, absolutely. But you can't just stop at the IFSP, then have to take it that next step into, okay, so what's actually happening? And then you have to be able to compare the two and say, did what was planned get provided? And it was the argument that we were able to make that roughly about 65 to 75% of what was planned got delivered. That pushed this along. Interestingly, since we went to fee-for-service, that rate went up, because if they don't provide the services, they don't get paid.
Right.
So kind of interesting.
And it clearly does have implications relative to productivity expectations, I would assume.
Absolutely. You know, particularly even right now during the COVID public health emergency, our providers going into this realized very quickly that if they don't provide some kind of visit, they don't get paid at all. So we were very quick to work with our Medicaid lead agency again and they're called provider bulletins, but also we amended our procedure to allow for remote early intervention to bill Medicaid the same way as in-person does. And that helped to keep the programs afloat, because it is just another way of providing EPSDT, early intervention services. So actually, I think had we not gone to fee-for-service, this might have even been harder, but the utilization is very important to the programs.
Let me shift gears a little bit here and ask you, coming out of this in terms of both the process of the how and then the execution of the, I guess, of the what has the implication been for your private insurance billing or participation in the program?
Well, previously, the billing of Medicaid and the billing of commercial insurance were two totally separate processes. Even when we had a billing contractor, he only did his company only did third-party commercial insurance. Our Department of Administrative Services was who billed Medicaid on our behalf when we had a bundled rate. Mm-hmm. This shift helped us to find a contractor through an RFP process that was able to do both pieces. So the process is exactly the same regardless of which third-party payer is being billed. And that also allows us greater efficiencies. It took some of the weight off of the programs. And we now have this combined data. You know, before, trying to report on utilization or Medicaid payments under a bundled rate through DAS as opposed to the commercial insurance, it was just a mess. Now it's nice and tidy. We also got them to pick up our family cost participation fee administration, which was yet another thing that the lead agency had been doing, but as we lost staff, we contracted it out. And really now all of that is under one house. It's really helpful.
And have you seen increases on your private insurance side?
Not really. You know,
let me rephrase the question. Have you seen changes in your private insurance side pre-COVID as opposed to during the current period that we're in?
You know, I'm not sure that we've had enough time go by to actually compare COVID to pre-COVID when it comes to that, because it took a little, you know, a month or two for services to get up. We saw a huge drop in referrals and a huge drop in utilization, because remember, 50% of our state Part C funds go to supporting children and families when the child has an autism spectrum disorder. and they're not sitting in front of laptops for 10 hours a week. So they saw the biggest decline. Anyway, then the claims go out to the third-party payers, and with the exception of Medicaid, who has their 2-week cycle, which is very nice, the commercial payers are taking longer, and we had to get an executive order to extend it beyond 3 because we started doing that. I think after a couple of more months, then the summer came, so it'll be really interesting to see the difference, separating it out from the overall drop in services. We don't really look to our commercial insurance for much. I think it was our insurance commission who told us that about 97% of the families in Connecticut are insured by self-funded plans, which means they're not required to follow the state statute. So if they are paying for it, they're doing it because it's what's right for their clients, I guess. But it's not like they're required to. So we're still tackling that. We're going to start with autism and then move on from there.
Yeah. I think an awful lot of that is also directed towards the employer who is making the decision to self-insure and essentially saying to their clients, meaning the lead agencies at the program level, you don't have to do this. And I think that's an ongoing challenge across the country for any early intervention system. Is sometimes you're not sure who it is we're trying to organize this around, and I'm hesitant to say against, but with, because someone may just simply not want to do it, where an insurer might be someone in the insurance plan itself who has kids in EI and really benefits from it and likes it, but that becomes its own challenge. So we're not like super close to time, but I guess I wanted to ask you if there are questions that I have not asked you that you would like me to ask you to be able to sort of more fully or round out the conversation if you feel that I haven't asked you something that's important.
I think I would stress the importance of thinking through every piece of it before you take the first step, to the extent that you can. I mean, I mentioned the 1915 B4 waiver, but that was massive, because had we not been able to do that, or were that not even an option, I think we would have fought it a little bit more, because we would have said, we cannot open this up to any willing provider. But if you don't even know that that's an issue to address, then you don't know whether or not to have the battle. We then, of course, for the first couple of years, have to renew the waiver. The waiver has a legislative process. We had to explain it. They were mixing up the 1915 B4 waiver with the waiver that they may be asking for Medicaid managed care or other waivers, like in adult DD/ID services. So you end up just asking a lot of questions, trying to get as informed as you can. But the minute you hear something that doesn't sound right, like, well, of course, they can't bill for more than one service per day. It's like, no, wait. We have to fix that, because they have to be able to bill for more than one service on one day. In fact, one practitioner might need to go to the home, have a conversation with mom, have mom raise up something that she would like to talk about with dad. The practitioner leaves, goes home, eats dinner, and comes back that evening to have a conversation with dad and to show dad some of the activities, or hear from dad what he wants to focus on. And that has to be billable. And the other thing I think was critical was the role of our ICC and our providers in advocating. Once they got off the "we don't want to do this" train, there was the, okay, if we're going to do it, we're going to do it right approach. And so they testified at the public hearings, and because of the 2 ICC members that are also providers who testified at DSS's public hearings about the state plan amendment, we got joint visits covered, but we also got transition conferences and attending PPTs, which is our version of a IEP meeting, covered. And it all came down to how we defined what an early intervention visit was. And those little things make a big difference as you move along.
So this is my last question that I would want to ask. It's a twofer. One is, how long have you been in the implementation stage of this? And two, I think you partially answered this just now, is what has the relationship with the provider community, how has that evolved given the sort of opposition to it in the beginning?
Okay. So when this whole thing was supposed to start, it was supposed to be April of 2017. Well, that didn't happen. Then it was July of 17. Then it was September, October. It ended up being November of 17 by the time we got the state plan amendment approved by CMS and we got the vendor contracted with the state and we got the data systems. I have to tell you, that's another piece of this that I absolutely didn't anticipate. We've got 4 different data systems in 4 different entities. So the BERTA3 data system, the private contractor billing data system, the MMIS data system interface, and Change Healthcare, which is the healthcare exchange that our third-party biller uses. One little data glitch in any of those can cause a whole batch of claims to deny. So really the first probably 6 months was just testing and testing and testing. But then on November 1st, we switched. And it wasn't until April of 18 that the programs could actually see their billing data in the third-party billing vendor's data system because of a glitch on our end. And it was an absolute nightmare. So I remember Maureen Greer saying, you need to have at least a 6 to 9 month pool of funds available to push out to the programs before this shift happens as cash advances, just to tide them over. And boy, did we need that. We also got our Medicaid lead agency to do the same thing. They put forward cash advances and then withheld 20% from each payment once or per month, once the billing actually started. But the data systems were amazingly complicated. We had a developer who was not in the right country. I mean, he just literally, he wasn't in the right field. So anyway, after the data started flowing, that was now April of 2018, it still took a while for the programs to get used to looking at their own data, running their own reports, understanding. Many of them had to hire people specifically for working claims. They didn't even really know what working claims meant, so they had to hire specific people to do this. Our early adopters are doing much better. Our larger agencies who maybe are doing this for other lines of work, doing much better. That still took a while, and every time there was a bug or a glitch or a payment or an overpayment and a take back, it just ended up continuing to be messy. Throw into this, we were required to do a request for proposals to open up the procurement of birth to 3 because we had not done so in about 6 years. And we were able to convince our Office of Policy and Management that now is not the right time for this RFP. We don't even know how we're paying programs or if we're paying programs, let alone how they're going to get paid once this is done. Mm-hmm. So that delayed us even further. We finally did the RFP. It went out to the public in December of 2019. And prior to, no, actually it was published in October of 19. So prior to that RFP being published, one of the things that the programs kept saying is this fee-for-service model is going to make it so you don't have enough programs and nobody's going to apply to be a provider and families are going to have to wait. When in fact, every single program that was providing services in September applied to provide services in October.
Right.
So we thought that was a statement to the fact that the transition had been successful. And then as a result of the RFP, we actually went from about 27, 28 programs down to 19. And we're just seeing greater efficiencies, bigger programs, managing it. And even through COVID, some are having a hard time, but a lot of the programs are like, no, actually we're fine. So the relationships are with the ones who are going to be with us long-term are fine.